Doctor, I've seen a recent article about revascularization of intermittent claudicants leading to higher rates of chronic limb-threatening ischemia and potentially amputation. What is your experience?
My experience is the article that you just mentioned, which claims that endovascular atherectomy therapy leads to more complications such as more repeated therapy or amputation, which is actually not true. The data that they claimed is, number one, very small cohort and is not present at CMS because only 5% of the procedures or patients that are being done or treated in an outpatient center is within the CMS database. So there's 95% of those patients missing. So you can't really make such claim on such a small number. So we went ahead actually based on this and we looked at 72,000 patients from CMS database, looking at patients being treated with atherectomy versus surgery versus stents and balloon angioplasty in the hospitals. And we found actually within the hospital system that atherectomy is the most superior form of therapy for patients with critical limb ischemia. And that was published in the American Heart Association journal. And to show you that, with such a large cohort, statistically, atherectomy ended up being the best form of therapy for those patients. So to answer your question now, scientifically, this is scientific answer, that atherectomy is superior to stenting, balloon angioplasty, and according to the paper we published, also to surgery in critical limb ischemia. So this article that you're mentioning does not really stand any scientific support to support their claim. So therefore, I don't believe that claim. It's not real and it's not true.
Do you think it's really, and this might be a loaded question, could be considered an unfair question to pose to you, but I think it's worth stating that, do you feel as though it could be simply competition between hospitals and OBLs, and so many doctors, vascular specialists, are leaving the hospitals because they're limited within the hospitals by red tape and standard protocols, and their ties to a certain amount of cost efficiency and reimbursement numbers. And these doctors are like, you know what, we want to go do our own thing because our priority are the patients.
I got to tell you, you are a brilliant lady for asking that question, because this is the reality that we're facing, and you can look it up and you can see it right now. Physicians such as myself or other physicians that do primarily critical limb ischemia are being sort of squeezed out of the hospitals because the hospitals are not able to support the amount of work that we have to do to accommodate the very sick patients with critical limb ischemia. As you know, critical limb ischemia patients have much higher mortality rate than most cancers. So the hospital is not giving us enough time in the cath lab. We don't have enough time to see those patients, to follow those patients. So here in the outpatient center, for example, in our center, we have all the time in the world to take care of those patients. We have 2 operating rooms here, so we can operate on these patients when needed. Remember, these patients don't have a cure. There's a therapy for them, there's a treatment. So we do treat them in the timely fashion that is required for them to heal, not similar to what we experienced in the hospital where we had to wait sometimes weeks at a time to treat some of those patients. So it's so hard for me to believe that doing the things that we're doing today for patients with critical limb ischemia in an outpatient setting is something that hurts the patients or actually increase the rate of amputation. Is on the contrary, patients that are being treated in outpatient centers tend to have less amputation rates than otherwise. And we have a major paper coming out soon to show that there's scientific evidence that what we're doing in an outpatient center is extremely safe, extremely valuable, and it does save amputations from happening to patients.
I just want to leave people with the fact that this is not, we're not attacking hospitals in this at all. It's just purely that this article came out that is purely biased towards hospitals. And so we wanted to provide a balanced perspective and the other side of the story as well, just to make sure that everybody has the whole story before making any sort of conclusions, right?
Absolutely. We are, as you know, we are all grateful for hospitals and their presence and emergency room and what they do for patients and the care that our patients can receive. But let me give you one reality check here. The patients with critical limb ischemia, the average time of the patient that goes to an emergency room to receive care is about 9 days. And again, this is not my opinion. This is something that is published based on a large data from CMS. And then at the same setting, another study that was published that showed if you present with rest pain versus an ulcer versus a gangrenous toe, the outcome in terms of death and how long you're going to live, and I believe it actually, if you present with a gangrenous toe, you're going to die much quicker than if you present with an ulcer or rest pain. And we treat those patients nonchalant, no urgency, no time is tissue, versus someone that comes in with chest pain. They immediately get all the care in the world, and they go home the second day or third day, where actually the patient that came in with rest pain or an ulcer have much higher mortality or death, chance of death, than the patient that came in with chest pain. But we can't really convince anyone to change their way of looking at those poor patients with critical limb ischemia. So my advice to every ER physicians in the country, a patient that presents with a gangrenous toe or an ulcer underfoot, they are very sick people and they only have an average of lifespan of about 2 years. So do everything you can to get them care ASAP. And if you can't provide that care for them in the hospital, send them somewhere else where they can get the care within 24 hours.